Thank you for joining today's webinar. Dr. Danielle Pier will now begin the program. Doctor?
Hello, everyone, and welcome to today's webinar, Perinatal Stroke, Risk Factors, and Present and Potential Future Management. I am Dr. Danielle Pier. I'm an academic clinician educator who is board certified in child neurology. I have a special clinical interest in fetal and neonatal neurology and a deep commitment to residency education and training. I'm delighted to be here as a moderator today. Before introducing my colleague and our speaker for today's program, we would like to share some information about the Foundation for Women and Girls with Blood Disorders. The Foundation's mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. With this, FWGBD aims to provide education to healthcare professionals on the medical consequences and unique issues for women and girls with blood disorders. Since its inception, the Foundation has focused on realizing the vision through these objectives, as you can see displayed here. To ensure the best quality during our program, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with myself and Dr. Grabowski at the end of the program. You can submit your questions during or after the presentation portion via the chat box in your control panel on the right-hand side of your screen, and we will address them during the Q&A session at the end of today's presentation. The next few slides detail the accreditation process. In support of improving patient care, this activity has been planned and implemented by CineMed and the Foundation for Women and Girls with Blood Disorders. Continuing education credits will be provided, and a follow-up email will be sent to attendees explaining how to obtain 1 hour of CME or CE credit for the program after its conclusion. The learning objectives for this program are to describe perinatal arterial ischemic stroke, including the risk factors, discuss the present and future therapeutic interventions for perinatal arterial ischemic stroke, and to explain the importance of counseling parents of an affected child regarding the treatment and management of care for the child and future pregnancies. All provider employees in control of content have indicated that they have no relevant financial relationships to disclose, nor do any of the speakers. I do not have financial relationships to disclose, and Dr. Grabowski is a consultant for Sanofi Genzyme. All attendees will receive an email an hour after the program's conclusion with the evaluation and this link to claim your 1 hour credit. The accreditation overview is also available as a handout, and the link will be shared again at the conclusion of this program. Before we begin our presentation, we'd like you to do a quick poll to see how many of people are joining us today with others and to assess your current knowledge of this topic. Please take a moment to answer the poll questions on your screen. The next question is, what is the incidence of perinatal arterial ischemic stroke in term births? 1 in 400, 1 in 4,000, or 1 in 40,000? Okay, next up, perinatal strokes in the term infant are primarily arterial ischemic, hemorrhagic, or both. All right, and lastly, a serious maternal condition predisposing to perinatal stroke is preeclampsia, diabetes, or both. Thank you for all your participation. We will ask these questions again following the presentation. And to that end, I will now introduce our speaker, Dr. Grabowski. Dr. Grabowski is a practicing pediatric hematologist oncologist at Massachusetts General Hospital with interest in bleeding and clotting disorders, pediatric stroke, retinoblastoma, immune cytopenias, and general hematology oncology. He also directs an active research program, both as the director of the Cardiovascular Thrombosis Laboratory and as director of the MGH Comprehensive Hemophilia Treatment Center. He is a co-founding director of the MGH Pediatric Stroke Service. His medical degree is from Mayo Medical School, while his doctorate is from Columbia University. He has completed fellowships in cardiovascular physiology and biophysics at the Mayo Graduate School of Medicine and in pediatric hematology oncology at New York Presbyterian Weill Cornell Medical Center and Memorial Sloan Kettering Cancer Center. He's an associate professor of pediatrics at Harvard Medical School and is the founding president of the Thrombosis and Hemostasis Society of North America. And with that, Eric, please take it away.
Thank you very much, Danielle. That was a wonderful introduction. I want to say at the outset, excuse me, that I have a number of very valuable co-workers in the whole area of perinatal stroke. And these include Dr. Pier, whom we just met, Dr. Ferdi Bonanno, who co-founded the stroke service with me some years ago. He's now retired. And Dr. Patricia Mussolino, who is a superb stroke neurologist who takes care of older children. In addition, we have Kenda Al-Hadid, who's a new faculty member, Dr. Molly Smith, who's a fellow pediatric hematologist, and a new nurse practitioner to our group, Ms. Erica Podias. Now, the topic of neonatal experience is one which depends on the eyes of the beholder and the eyes of the participant. But what I'm going to do is present to you our own experience over the last 15, 20 years at Mass General Hospital, but also cite, as you heard, the incidence, risk factors, and some ideas towards acute management for the future, as well as for the present, for perinatal stroke. I'm having some trouble advancing the slides. Perhaps, Wendy, I can ask you if you could do the next slide. We belong to a group called International Pediatric Stroke Study. This is an organization which is founded by Dr. Gabrielle de Weber, who was trained at Mass General and is now at Sick Children's Hospital in Canada. This group was formed in order to stress the importance of pediatric stroke, show its incidence, and also to begin studies which can only take place given the uncommonness of this condition through international collaborations. The stroke study group now is present at 100 centers, actually more than 100 centers in 34 countries, and so far has enrolled more than 8,000 children. Next slide. The prevalence of pediatric stroke overall, that's for all ages, is on the order of 20 to 23 per 100,000 persons. This really isn't rare. It's not an everyday occurrence, but the incidence is comparable to that in young adult stroke, and it's several times more frequent than the incidence of severe hemophilia A. The incidence of newborns is the predominant component of this, about 20 newborns per 100,000, or about 1 in 4,000. Versus a lesser proportion, but still important, of about 1.2 per 100,000 in older children. This compares with the 17 to 23 per 100,000 in the young adult, referring to large vessel ischemic stroke. And these numbers are consistent with what we see at Mass General, more than 30 pediatric strokes each year, a large number of them in the neonatal intensive care unit or referred there. And at least 650, probably more, adult strokes each year. Slide, please. The purpose of the diagnostic steps is initially to exclude CNS hemorrhage. because bleeding in the brain would obviate the use of an anticoagulation or an agent of anticoagulation when indicated. It's also important to make sure that the event is not primarily a hemorrhagic one, as opposed to an ischemic one, which is point number 2. We want to usually confirm that an acute ischemic event has occurred, so we can look for a source of thromboembolism and manage that if we can. Thirdly, determine the extent and location of acute cerebral injury. The outcomes in terms of motor or cognitive deficits depend not only on the extent of the stroke, but also its location. Determine the patency of the presence of dissection or tears to major neck and intracranial arteries. In young adults and in adolescents especially, there's a tendency for relatively minor trauma to give rise to tears or dissections in these feeder vessels, very important arteries. The mechanism of this is not entirely understood, but they tend to occur where the vessels pass over bony structures, such as the skull base. And finally, to determine the relative cerebral perfusion that remains after a stroke to help predict what territories of the brain remain at risk. Haven't actually had a frank infarction, but there's a lack of blood flow, there's ischemia, and it provides a greater impetus to make an intervention to prevent progression of an evolving stroke. Slide, please. Between 2007, when we started our outpatient clinics, our service started actually formally in 2002. Between 2007 and 2017, we compiled the first 100 consecutive perinatal strokes that we've experienced and broke them down by eceology. Again, these are all for term infants. More than 3/4 are arterial ischemic in nature. Cerebral sinus venous thrombosis, which means thrombosis of a draining sinus or passageway in the brain, or cortical vein, accounts for another 10%. Intracranial hemorrhage, intracerebral hemorrhage, accounts for about 8%. And there's lesser numbers that are antenatal, not very well understood, from external compression, as in child abuse or trauma, and infection. Next slide. Now, one of the surprises when we first put our data together some years ago was that not all perinatal stroke is obvious in the perinatal period or even in infancy. About 2/3 present within the first 7 days of birth. That is with a seizure. Seizures will occur, but actually we've never seen one at day 8, 9, or 10 or thereafter, except until a child is older. But most of them present with seizures, a smaller number with apnea or obvious poor perfusion. At least 1/3 present weeks to months to years later, chiefly when a pediatrician recognizes precocious handedness. Normally don't have handedness or handed preference in developmental physiology in a child until about age 18. But being a lefty or righty prior to that age should raise a question. Developmental delay that's not anticipated, or unexplained hemiparesis. So then brain imaging is usually done, a neurologist is consulted, and the imaging shows encephalomalacia consistent with what's called a remote infarct, which means it occurred in the past, so weeks to years before, weeks, months, years before, but we can't date it precisely. But we attribute it to the perinatal period because we really know the high incidence of what happens in terms of stroke incidence in the perinatal period compared to the period of the bulk of childhood. Next slide. Now, arterial ischemic stroke in newborns is usually, in my view, due to a perfect storm of 3 major factors. Maternal conditions like diabetes, preeclampsia being 2 leading ones, labor and delivery gone bad. I call it stressful labor and delivery. And finally, thrombophilia, that is risk factors in the blood plasma itself, which increase the risk of having a perinatal event. Strokes are predominantly caused by stressful labor and delivery. Maternal factors can also be primary causes. thrombophilia is usually contributory, it's usually not sufficient, but very much implicated in the likelihood of one happening. We find that about 30% or more of perinatal strokes are associated with a plasma phase-based risk factor, which has implications for closure for a family. And why me? Why my child? And also does portend a risk for future clotting events outside the brain. Next slide, please. Recurrent thromboembolic events are really rather uncommon. And one study by Kernick performed with Dr. Novak Godel in Germany, only about 3% of a series of 200 plus neonates had a recurrence. Again, this reflects the dominance of maternal and labor delivery factors. Such events still are associated with an increased frequency of plasma phase risk factors. Next slide. This is shown in one of two of the primary leading pediatric studies. Next slide, please. I think somehow there was a slide missing, but that was to show that there was a study done by Kennett of over 2,000 children from birth to about age 21, in which thrombophilic risk factors are present to the tune of about 60%. One of the leading factors or risk factors is an entity known as lipoprotein a. Now, this is a low-density lipoprotein with a high degree of sequence homology with plasminogen. Now, plasminogen is important because it's a key player in clot breakup or thrombolysis, which is a normal part of hemostasis and coagulation. One can have a hypercoagulability state if you have a deficiency of plasminogen or plasminogen which is dysfunctional. Elevations of lipoprotein A confer an increased risk of arterial but also venous thrombosis, because since lipoprotein can compete with plasminogen for a specific binding site on the endothelium, on the vascular endothelium, by competing, it displaces the plasminogen and makes it inactive. Secondly, lipoprotein A can bind directly to one of the principal anticoagulants in blood, tissue factor pathway inhibitor, allowing tissue factor to run wild, so to speak. Tissue factor and its activation through other clotting factors, especially factor 7, is always present in some low level and operating at some low level in the body. But if it's released from its constriction or regulation by a tissue factor pathway inhibitor, it becomes much more important. And finally, this lipoprotein carries cholesterol to the vessel wall and can cause direct vessel injury. Next slide, please. The poster person, if you will, for elevated lipoprotein A is Arthur Ashe, whom some of you may recall was an outstanding African-American athlete who won Wimbledon and the US Open pretty much in almost the same year. Besides his, notwithstanding his high degree of physical fitness, he suffered a major heart attack in the early 1980s when I was at Cornell in New York. My medical hematology colleagues took care of him, and they studied his risk factors and found that he had elevated lipoprotein A. And Mr. Ashe made a big point of wanting hematologists and indirectly the public at large to be aware of the importance of this risk factor and that studies be done in the future to benefit others who might be so affected. Next slide. Risk factors, again, include maternal conditions, two of which I mentioned, labor and delivery stressors, which include a prolonged second stage of labor. According to the Kaiser Permanente study, 4 hours or more constitutes prolonged labor in the second stage. The use of a vacuum extraction or forceps, abnormal fetal heart rate, and finally, emergency C-section is itself a form of marker for stress and risk and high risk. Next slide. Placental and fetal factors matter as well. Our institution has been one of the pioneers in looking at each and every placenta that's delivered at our institution in an effort to study these. It is now believed, in part through these studies, that many thromboembolic phenomena involving strokes in newborns originate in the placenta, and that a clot embolizes from the placenta through the antenatal circulation to the right side of the heart, and then through pathways such as a patent foramen volley and others, crosses into the systemic circulation to cause stroke. There's also fetal vascular anomalies, cardiac defects, fetal thrombophilia, where the influence of the father and mother both can matter, and infection, such as chorioamnionitis. Next slide. Thrombophilic risk factors for total ischemic stroke in children were best depicted in a study of which we were a part, and it involved 22 centers around the world. And the lead investigator was Dr. Gilly Kennett from Israel, who was a pediatric hematologist. The leading risk factor in terms of relative odds of stroke was deficiency of protein C. So-called antiphospholipid antibodies, or lupus anticoagulant, was second, but lipoprotein A elevations were third, with a relative risk of 6.5. That's quite significant. Next slide. The first case I want to show is of a little boy who was born at 40.5 weeks gestation, a normal birth weight, uncomplicated vaginal delivery. APGAR is not too unreasonable, but the evening of his first day of life, he started showing seizure activity, oral smacking, eye blinking, clonic activity. And imaging showed a rather large infarct, as you can see, in the right side of the brain. Next slide. Now, we looked for risk factors in his plasma phase. He had none. We actually don't do that in real time. We'll send labs off and expect them to come back later. But decisions are made without benefit of these for the most part. His echocardiogram, which is an important thing to do in a workup, showed thickening of the septal leaflet of his tricuspid valve, which suggested a deposition of thrombus, platelet thrombus, on this valve. And in view of the fact that he had a patent foramen volley, which most infants do anyway, but with right to left shunting, we felt this was the smoking gun of his stroke. Now, I said earlier that we believe the emboli originated in the placenta, but now once the baby's born, the placental part of the circulation is no longer part of the baby or the conceptus, so that's out of the picture. But sometimes thrombus can remain in the heart, thrombus en route from the placenta to the systemic circulation. And when we see that, this is one of the few indications for anticoagulation in a newborn having this type of stroke. And the reason for that is obvious, because we have to treat the remaining clot burden. Next slide. Our strategy has been to use low-dose standard fractionated heparin with subsequent escalation to full dose over 24 to 48 hours. We do this in a circumspect manner, if you will, because of the lack of evidence-based medicine to support anything more aggressive. But we do follow with heparin levels and short interval follow-up MRs of the brain. And this allows us to find our way forward. We have no bleeding at, say, 24 hours. We can escalate the dose again and try to get up to therapeutic. At the same time, we seek to control seizures and start our search for congenital and acquired risk factors. Antiphospholipid antibodies are an acquired risk factor, but the rest of the items I indicated in terms of risk factors from the Kennett study are primarily congenital. Next slide. Another case is cerebral venous sinus thrombosis. As I said before, too, sometimes strokes arise because there's an occlusion in the venous drainage of the brain. This could be through passageways or slits between parts of the brain, known as sinuses between parts of the brain, or cortical veins. When these become occluded, the vessels can become friable under increased pressure. Flow cannot exit the brain, and therefore oxygenated blood cannot enter the brain, and thereby you get ischemia and infarction. Next slide. In this case, we had a term boy once again, where there was a vacuum-assisted delivery, so you raise a question mark, did something happen because of that or related to that? Normal birth weight and head circumference. He was intubated because he had respiratory distress. Next slide. However, imaging and a CT venogram was performed, showed partial compression of the superior sagittal sinus right in this region here. And this was associated with finding of a thrombus in his cerebral sinus vasculature. The next slide shows very commonly, if we look at this diagram, we'll see thrombus in one of the transverse, the right or left transverse sinus. This is superior sagittal, can be here. And also there's a straight sinus. Those are the principal passageways of venous drainage, in addition to other structures I haven't identified, the cortical veins. Now, there's a sort of Times Square of all the sinuses called the torcula, right about here. And when you have clotting here, that's an especially worrisome sign. It's known in the literature in neuroradiology and neurology as a double delta sign, which is identified by Dr. Bonanno, my colleague who, as I mentioned earlier. So this was one of his great contributions to the field of neurology and stroke. Next slide. Now, there's at least 3 adult trials, but no systematic pediatric trial as yet, although there's efforts to have one, which explore the role of heparinization in cerebrosinus venous thrombosis. The adult trials also show that there's no harm and likely hope of benefit. The patients that were enrolled in these trials were not enrolled right away, but after some time delay, and I worried about that when trying to extend this to children because we often want to start right away, and there's no evidence-based medicine to help us in the acute period. Next slide. Now, nonetheless, the use of heparin in some form, based on the adult outcomes, appears to lead to a diminished incidence of new intracranial hemorrhage and improved survival. And this is notwithstanding the fact that many of these sinus thromboses are associated with a phenomenon known as hemorrhagic conversion. That is, the territory that is occluded by the venous thrombosis because of vessel friability and lack of oxygen turns into bleeding. And that bleeding, however, is not a contraindication to anticoagulation. That's the only time I know of that having frank bleeding is actually an indication to anticoagulate, because the bleeding can only get worse if the congestion and thrombosis progresses. Next slide. So therefore, we come to a sort of a consensus of what to do in neonates. There's if you had no anticoagulation, a number of these, in an era before we were brave enough to start using heparin on a more routine basis, there was about a 15 to 20% incidence of progression of such sinus thrombosis in children, based on our experience from the 1990s and that at Denver Children's Hospital under Dr. Marilyn Manco Johnson. The risk factors for such an event as sinus thrombosis include involvement of a dominant transverse sinus, I should say for stroke with such an event. The dominant transverse sinus, if you lose the major conduction or conducting pathway, and the other one is a minor tributary, a minor vessel, a minor passageway rather, you'll lose drainage. Or involvement of the torcula. Seizures is a risk factor. The presence of intracranial hemorrhage in the term newborn in the absence of trauma, unless it's in a separate location of the brain and by separate etiology. For example, in an arteriovenous malformation. But if it's associated with the sinus thrombosis, that's a risk factor for progression of that sinus thrombosis to more harm. An underlying bleeding diathesis is not too common. Positive family history of thromboembolism, which is fairly common. Next slide. Now, we divide everything here now to an asymptomatic child versus a symptomatic child. An asymptomatic child has no neurological changes, yet there's sinus thrombosis, and there may not be actual stroke. There's no consensus at the present time concerning the use of anticoagulant therapy. In the absence of intracranial hemorrhage, though, we prefer to use prophylactic low molecular weight heparin because although some children will do well with nothing, no treatment, there's a significant percentage who will progress. Next slide. In a symptomatic child, there is a consensus among most pediatric coagulationists to use standard unfractionated heparin, but no data to support or not support its early use in the first hours. Thereby, Dr. Bonanno and I started a procedure of using a very small dose, 10 units per kilogram per hour, and escalating over 24 to 40 hours using serial MRs to try to find our way to therapeutic dosing. Only once in a year over the years have we found hemorrhage that required us to stop anticoagulation. And that was because of an anomalous passageway with a vascular malformation that we were not able to recognize up front. So this has actually been very successful. The starting dose of 10 units per kilogram per hour comes from work of Dr. William Hathaway, who was the mentor for Dr. Manco Johnson. And in that work, that dose he came up with to treat umbilical artery catheter thrombosis in the setting of interventricular hemorrhage in preemies. And when that seemed to be safe, to use. And I started to use that with Dr. Bonanno in first this group of children, and then later in older children. Next slide. Case 3 is a newborn with moderately severe hemophilia A, massive fetal maternal hemorrhage, and perinatal stroke. So here we do have a bleeding diathesis. That's congenital. Next slide. So a little boy was born at 39 weeks into one of our community hospitals, happens to be a Newton-Wellesley hospital, by emergency C-section for slowing fetal heart sounds. This is one of the risk factors I mentioned very early in this talk, and loss of fetal movement for about a day. APGARs were moderately okay. The child was then brought to the special care nursery, a good effort to feed, but he was extremely pale. Our heel stick showed a hematocrit of only 15. It should be 40 or even 50. And then a central CBC showed actually a lower value. Centrals are more accurate, with a hematocrit of 12.4. A Kleihar-Betke stain and a degree of the stain was able to allow us to infer that this child had lost more than half of his blood volume by bleeding into his mother. Next slide. So immediately, there are two things we did. Well, he got blood to raise his grit up to a safer level so he can have perfusion to various parts of his brain and his body. Next slide. While we obtained, next slide, obtained some critical labs that were able to run within 24 hours, which showed a PTT of 68.7 seconds, consistent with a hemophilia-like disorder. His factor VIII level was 2%. The other factors were all normal for age. The 2% proved actually to be somehow high because subsequent numbers have been undetectable. Next slide. At the same time, we did an MR, brain MR, because we were very worried about intracranial hemorrhage. We found none. And diffusion weighted images, which usually are those that we use for stroke, did show a small ischemic infarct of all things in the right frontal lobe. And this, if you can see in the next slide, is right here. It's in the right frontal lobe. This is an area of infarction by diffusion weighted imaging. And it's in what we call a watershed location. That is, various parts of the brain are all draining from this area, which means it's an area which is most susceptible to lack of oxygen if you have decreased oxygen delivery. And we did, because this hematocrit was so low that the oxygen delivery rate, which would be the product of oxygen concentration in the red cell times the red cell number or density of blood, was quite low. So we suffered a stroke. We went on further and found the next image. Go ahead, please advance the slide. An apparent diffusion coefficient image. We'll skip this one. And we go directly to a very informative image. Susceptibility weighted imaging, which tells us whether there's blood. Susceptibility of the iron in blood alters the B field in MR. So we did not see anything there, meaning there was no blood, no bleeding. And then a decision I needed to make at this point was whether to give clotting factor concentrate or not. I chose not to because there was no bleeding. And it turned out by follow-up MR scans, he was all right. And he did not progress. Giving factor unnecessarily at this age is wrought with some risk, because there's a risk of an inhibitor of about 25% with hemophilia A. And to get an inhibitor with a first infusion, which is, they do occur in the early exposures to factor, would be disastrous. Nonetheless, we would have done it if we felt there was a need. I should point out that we're blessed because for the last decade or so, we've had access to a rapid brain MR that does not require anesthesia even outside the neonatal period. So for children who are aged 4 months, 5 months, a year or two, we can do rapid brains which do not require general anesthesia. Newborns, of course, you can get them to sleep or hold still without anesthesia. Next slide. Placental pathology was showed no edema or eye drops to support some chronic hemorrhage. So this was a very abrupt acute event, what happened. And then our pathologist who's in charge of placental pathology found no AVM, so intravenous malformation. So we conclude that this is a bleed which is driven primarily by the child's hemophilia, an unfortunate rupture of a vessel that drained blood from the baby into his mother. There's some of that happening in many pregnancies, but this was really accentuated. Next slide. Mom was tested for a genetic mutation and confirmed that she's a carrier of hemophilia. Next slide. Long-term complications. Mortality, we're fortunate we're not quite this high, but all centers taken together, especially those who don't have access to as many facilities as many centers can be blessed with, it's up to 5%. Recurrence is uncommon. Seizures, 10 to 25%. Focal motor deficits, about a third of such children. There's a big question mark here about neurocognitive deficits, but they're not negligible. This is a biggie. And there's been an impression in the past that perinatal stroke, it doesn't have such a consequence in terms of neurocognitive problems later on in life. This is just not so. And it's one of the great efforts that Dr. Pier is helping carry out and studying children on an annual basis, at least, in our follow-up clinic. Psychological and behavioral issues, and also clotting events, which we have observed in one child who had AT3 deficiency and was not recognized. Actually, he developed a stroke. It was not recognized to be a stroke at another center, and we saw him for a clotting event in his teen years, which happened to be his third clotting event outside the brain. Next slide. Follow-up evaluations and post-stroke include physical therapy. These are measures, should say, as well as evaluations. Occupational therapy, speech and language, neuropsych evaluations, especially at age 3, and again, when a child's entering first grade. We look to see the trajectory as well as what areas need to be targeted for individual education plans, psychology and social work, and once in a great while, psychiatry. Next slide. What we've observed over the years is that neonates who present early have better prognosis than those with a delayed presentation whom we infer are also perinatal strokes. We don't know why. It could be a different biology, or it could be that they had some symptoms that were just not recognized and controlled, such as maybe subclinical seizures when they were first born. Those with arterial ischemic stroke tend to have more deficits than those with cerebral venous sinus thrombosis. And there's a correlation between the presence of motor deficits and both seizures and neurocognitive deficits later on in life. Next slide. So in summary, pediatric stroke services, I'd like to think ours as such, have, in terms of what it can do, have an important role to play in perinatal stroke. This means having a hematologist, a physiatrist, certainly a great stroke neurologist, and other participants in the overall effort, such as nurse practitioners, social workers, and physical therapists. Term newborn suffers usually arterial ischemic events. However, cerebral sinus venous thrombosis and intracranial hemorrhage also do occur, and cerebral sinus venous thrombosis warrants judicious use of anticoagulation. And in the years to come, we hope to have protocols that are more widely used and standardized among centers to apply anticoagulation. Intracranial hemorrhage, when it does occur, warrants a search for an underlying bleeding disorder or vascular anomaly. The child with hemophilia I mentioned actually 4 years later had a massive intracranial hemorrhage from an AVM, which happened to develop in the area where he had the ischemia or hypoxia. And we speculate that that may have driven growth factors to lead to the formation of an AVM, which took 4 years. Nonetheless, he was well treated. He had neurosurgery to remove the AVM when conservative measures did not work out, and he's had an outstanding neurological outcome nonetheless. Next slide. Stroke in childhood, while not common, is also not rare, about 1 in 4,000 live births, and is frequently unsuspected at presentation. The causes and patterns of pediatric stroke differ markedly from those of adult stroke, both in the scope and symptoms of presentation, and also the management. A coordinated pediatric stroke team is essential from the standpoint of effective and timely evaluation and management. Now, just a few words in the remaining few slides about treatment. The therapies, the very straightforward ones, include control of seizures, provision of oxygen, electrolytes and fluids as needed in the acute stage, use of anticoagulants, not common but critical when it is needed, early intervention and individual education plans, and speech, physical, and occupational therapies. However, there's great hope that we'll have some more medical management steps that one can take in the future. One is consideration of better therapies for some of the maternal conditions. Preeclampsia causes about 10% of perinatal strokes. If I fold into the matter, the strokes that have been experienced by centers which manage high-risk deliveries. And I put data together some years ago between Yale, where Dr. Michael Paitis was very active in high-risk OBGYN, and our center, and 10% of our combined stroke numbers were from preeclampsia. Now, preeclampsia is a prothrombotic condition, and childhood outcomes include death, intrauterine growth retardation, early premature labor and delivery. But stroke is a big one. So effective management of the preeclampsia, one would hope, would then lead to a decreased outcome of adverse outcomes in the child. Many cases of preeclampsia are refractory to steroids and plasmapheresis, magnesium sulfate, and more recently, use of Soliris for anti-C5 therapy. So there's a need here to fill a gap. Next slide. Anti-mannose binding lectin is an antibody directed against an entity in the complement pathway known as mannose binding lectin 2, which also controls several enzymes, 3 enzymes known as the mannose-associated serine proteases. Now, this pathway is upstream from that which anti-C5 therapy can affect. In other words, it's not touched by anti-C5 therapy. Yet, these enzymes can drive platelet activation, can drive trauma generation. This particular model is one from a different thrombotic microangiopathy, which I'm studying, but it may be a paradigm for what goes on in others, including preeclampsia, other thrombotic microangiopathies. On the other side of this slide is an antibody called 3G3. There's several antibodies available. This one I think is one of the better ones, directed against clotting factor 11A. And clotting factor 11A is pivotal to the contact pathway and the intrinsic pathway of clotting, and that the antibody can block activation of factor 12 and activation of activation by factor 12A of factor 11. So it's a reciprocal activation and it blocks. At the same time, it does not block thrombin generation. So it's almost like a dream or miracle anticoagulant. Next slide. Here I'm saying the same thing. One can use it alone, for example, in cerebral sinus venous thrombosis with hemorrhagic conversion or other hemorrhage without any real worry about bleeding. It again inhibits the reciprocal activation of factor 11 and 12, but without affecting downstream activation of clotting factors, including factor 10 and 9, and finally leading to thrombin generation. So again, it blocks thrombosis without causing significant bleeding risk. This is an anticoagulant of the future. It's in clinical trials now in adults. Next slide. Finally, there are neuroprotectants. One which has been developed by Dr. Michael Paitis at Yale, now in Miami, is placental implantation factor, which is important in normal embryology. And it may be neuroprotective in a situation where there's anoxia to the brain. Also, just a few years ago, a study was concluded called the Rhapsody trial in adults with stroke. Not children, but this portends what could happen in the future for infants and children. And what was used was a genetically engineered recombinant activated protein C, which is a very neat anticoagulant. This was used in combination with either tissue plasminogen activator or mechanical thrombectomy. And the Rhapsody trial showed a trend for decreased intracranial hemorrhage when this agent was added to either thrombectomy or to TPA. And with that, I will stop. And again, I'm very thankful to all my colleagues in our stroke service, and it's been a pleasure to work with them over the years.
Before the Q&A session,
Now,
we'd like to assess the knowledge gained during today's presentation. Please fill out the poll.
I actually saw the results of the poll when it was displayed briefly at the outset, but it looks like most people got the correct answer, 1 in 4,000.
Second question is up.
And again, most people got the right answer. There are both present, but it's amazingly how predominant arterial ischemic strokes are. They were 79% in our series, but only 8% were hemorrhagic only. Of course, there were some that were both.
All right, final question.
And again, the answer was both. Preeclampsia is the worst, probably worse of the two, but we see a lot of diabetes. So I'd have to truly say the answer is both.
Great, well, thank you all for participating. At this time, we'll proceed to the question and answer part of our program. As a reminder, participants can submit questions via the chat box in your control panel. All right, while we wait for some questions to come in, Eric, I can start with the question. What would you tell women or persons trying to get pregnant about sort of how to conceptualize this as a risk for them, whether or not they themselves also have a blood disorder?
I'm sorry, the question again is whether, say it again if you would, Danielle.
Sure. For persons trying to get pregnant or currently pregnant, how would you counsel them to conceptualize this risk with or without a coexisting blood disorder in themselves?
If they had underlying hypercoagulability disorder, then the woman should, of course, see a high-risk obstetrician gynecologist who could carry them more safely through delivery. There are regimens such as use of anticoagulants, plus or minus aspirin, or just aspirin alone in some instances. Guidelines for how to use these are still evolving. If the woman had diabetes or another systemic condition, then she needs good management of that condition. An endocrinologist would be in order for that. And again, a high-risk obstetrician in the case of something like preeclampsia. Or actually, preeclampsia tends to be run in a pattern. If you have it once, you have it for other children, and many mothers, if they experience that, should have a high-risk obstetrician anticipate that a second and third child may have the same thing. And they can be ready with proper medication, especially with magnesium sulfate, should a need arise.
Great, thank you. And what would you counsel families who've already had one child who had a perinatal stroke about their future risk for having subsequent children with this?
That's a good question. And I can only point to our own experience that you and I have had, and Pat, Dr. Rosalino, that we haven't seen that. It's not been a common occurrence at all. In fact, I can't recall maybe more than one time that it happened, which I think goes to say that individual risk factors in a pregnancy are dominant, such as the labor and delivery, which is maybe unique for every woman. Internal conditions, certainly those can be corrected after a first event and are usually identified. And if there's thrombophilia, not every child who has thrombophilia has a stroke. For example, in terms of lipoprotein(a), Julia Davies, who works with me, is trying to put together the data with me. And in our own series, we have 21% of our perinatal strokes are associated with an elevated lipoprotein(a). And we're trying to look for a control group, since it's very hard ethically to obtain one in this age range, to draw blood just for this purpose in healthy newborns. The next best thing is to get them from healthy older children. And the Kennett study finds an instance of 7% with elevated lipoprotein(a) in a normal control population in children old enough for whom it is ethical to draw blood for non-clinical purposes. That would suggest a threefold elevation in relative risk with that risk factor alone. But it also says that 2/3 of patients who have many patients who have that elevation may not actually present with a stroke.
Great. Okay, awesome. We have some really great questions rolling in. So first question for you, Eric. How often does a baby born to a mother or father with a clotting disorder end up with a stroke? And do we educate parents about this risk or send a letter to the OB?
We haven't really put our data together to answer that question because we're sort of trying to get all the numbers together for our primary perinatal strokes. We have tried to obtain confirmatory hypercoagulability values in parents, and we haven't had a high percentage. We have a number of them because we're doing mainly clinical follow-up and not a prospective trial. But that's the subject of a great prospective trial to collect all of that. If a father or mother had thrombophilia, what is the risk of a child with stroke? The risk is high, and I would infer that to be the case because we can't say the following. Where we do have more data, which is in venous thromboembolism at large, if you will, pulmonary emboli, deep venous thrombosis, and less common locations for venous thrombosis. Having a close relative, like a mother or father, affected increases your own risk about 3 to 4-fold. So it's a highly increased risk, but is not 100%. So we're lacking in a prospective trial looking at the values in parents and children. I will say one other thing. If there is such a severely inherited risk, and this is from mouse studies done in Wisconsin by Dr. Hardy Weiler, if you have a mouse who's homozygous for some of the worst clotting factors like antithrombin 3, both human and mouse, they do not survive. They do not survive gestation. So there's a rather very, very, very severe. So it really says there is a role for this, but to enumerate and to demonstrate the relative risk is a study yet to be done.
Yeah, I would agree, Eric. I think what's interesting is coming from like a non-hematology trained perspective, I certainly see a lot of parents who have very common things like, heterozygote NTHFR or von Willebrand disease. And often the child's stroke doesn't actually make sense with the inherited, risk factor from the parent. And so it's really hard to make those connections about causation versus some of these things that are just naturally, prevalent in the population. Would you agree?
Yes, that's a great point, Danielle. One of our tasks as hematologists, as well as with stroke specialists, is not to over overemphasize risk factors. For example, how many people in the population have factor V Leiden? 5% of those are European descent. That's only a minority who ever have a clotting event, even in their lifespan. Same is true, fewer than half of people who have protein C deficiency are ever symptomatic in their lifespan. The Kennett data alone, which pertains to pediatric stroke, although all ages of children, says there's 7% of normal healthy children and their controls who have a high level of Lp(a) but don't have a stroke. They don't have a clotting event like that.
Great. All right. So the next question, do you order a thrombophilia workup in every case? And if so, how do you approach timing of testing given inherent risk for low protein C and S levels, for example, in neonates due to immature hemostatic system?
We have the advantage that we have great normal ranges for protein C and protein S and antithrombin 3 throughout the newborn period, thanks to work by Neyman and Oski and by Margaret Karpatkin and Andrew and Maureen Andrew. So we do have that data. We don't have it for lipoprotein(a). That's been a challenge, except for one study out of Iceland. And we're looking for more data in that regard. But in terms of trying to demonstrate, what was the second part of your question again, if you would repeat that?
Do you order a workup in every case? And if so, how do you approach timing?
We do in every newborn case because we feel this is research. We're trying to learn. It's research in the sense we're trying to not miss something that could be very profoundly important. There are some people who do not do this, and there's a controversy over it. They feel it's futile. We do not think so. And I think my colleagues, Dr. Gilly Kennett in Israel and Dr. Ulrike Noack-Adel in Germany would feel the same way.
Yeah, I think in terms of timing, we try to batch it with other blood work. Sometimes it's inevitable that we have to, stick a child outside of a typical time. But for kids who are otherwise doing well and are healthy, if something wasn't able to be done while they were in the NICU, sometimes we'll wait until like a CBC and lead level is due. In Massachusetts, we often do it between 9 and 12 months to finish the workup for the reasons that Eric recommended.
It's uncommon to have a need for hyperacquired results right away. That's a misunderstanding. However, it's done in our acute care situation because we're drawing bloods anyway, so we'll send them. But you're right. In general, we don't need those results right away. And the timing, you could argue, you may have results which are more likely to be closer to the adult levels because hemostasis and these parameters will also undergo changes. For example, protein C normalizes after only several years in children. We do try to corroborate and verify our values, however, by getting a number in a child. And in a number of a number of children who have elevated lipoprotein(a), for example, we've obtained results in adults as well. And in 7 of 9 we've done, this corroborated or supported the fact that it was an inherited increase. We also, in the case of lipoprotein(a), always try to repeat it one time because it's an acute phase reactant. And it may be falsely elevated, but we don't find that actually a very common happening.
Great. I believe that's all the time we have for questions today. Thank you so much for joining us in this discussion, and for the presentation, thank you, Dr. Grabowski.
You're most welcome, and thank you, Dr. Pier.
On behalf of the Foundation, we would like to invite you all to join us for the Uterine Hemostasis Colloquium on March 13th in Coronado, California. The link can be found here and in the chat. Thank you for attending today. We will drop the CME link for your reference, and it will also be emailed to you within an hour.